Make the ground shake.
The topic of today's lecture is non-carious lesions, where we are going to speak about these types of diseases themselves, also their classification, and some diseases which corresponds to these groups. About pathological abrasion, weight-shaped defect, erosion, and dental necrosis. This topic is important because non-carious lesions of teeth, unlike carious ones, are not associated with the impact on the hard tissue of the microflora of dental plaque. The etiology and pathogenesis of these diseases depends on the period and duration of exposure to the pathogenic factor. The most common forms that occur after teething are erosion, weight-shaped defect, pathological exability, necrosis, etc. Similar clinical manifestation of a number of non-carious dental disease create difficulties in differential diagnosis. And the purpose, based on theoretical knowledge and practical skills, student must know the classification of dental diseases of non-carious origin, including international classification of disease, the feature of clinical manifestation, prevention and treatment of the most common nosological forms. Be able to carry out the grinding of the sharp edge of the hard tissue of tooth, carrying out remineralization therapy, and fluorization of the hard tissue of the teeth, restoring tooth with a filling in case of pathological erosibility, and have an idea of the mechanism of action of medicines for general and local treatment of erosibility of hard tissue of teeth. And our plan. First of all, we are going to speak about concept of non-carious lesions, classification, next pathological abrasion, wedge-shaped defect, erosion of teeth, and necrosis of dental hard tissue. What non-carious lesions are? Non-carious lesions of the teeth are much less common than caries and are not associated with exposure to solid tissue of the bacteria of dental plaque. The etiology and pathogenesis of these diseases depends on the period and duration of exposure to the pathogen factors. The main causes of the increase in the prevalence of dental diseases of non-carious origin. For example, deterioration of the ecology and physical health of the population, for example, diseases of endocrine system, digestive system, central nervous system, periodontal diseases, prosthesis and sealing errors, including those accompanied by occlusion disorders and recession of the gums. Also changes in diet and drinks, nature of oral hygiene, aging of the population, the appearance of new nosological forms like computer necrosis of enamel, hyperplasia associated with hypervitaminosis of vitamin D2, combined forms of tooth erosion, hyperesthesia, including those associated with the use of bleaching and photocomposites. And there is classification of non-carious lesions of teeth. And we have two types of classification. The first one is clinical classification. It includes two groups of pathology. The first one is pathology, which arose in the period of teeth development before eruption. And this group includes such diseases like hyperplasia of tooth enamel, hyperplasia of tooth enamel, teeth fluorisis, hereditary disorders of tissue development, medicamentous and toxic disorders of development of dental tissue, and the second group of pathology, which are after eruption. And there are pathological abrasion of teeth, weight-shaped teeth defects, erosion of tooth enamel, trauma of teeth, necrosis of hard tissue, hyperesthesia of teeth of hard tissue. And the second classification of non-carious diseases is International Classification of Disease. And these previous groups corresponds to groups of different diseases, and each group has code, special code, according to International Classification of Disease. The first group has code K00, and there are several diseases which appear before eruption, disorders of tooth development and eruption. And there are several diseases with code K00.0. For example, these diseases is called anodontia, hypodontia, oligodontia. Next, K00.1, supernumerary teeth. Point 2, abnormalities of size and form teeth. Point 3, mottled teeth like dental fluorosis. Point 4, some enamel hyperplasia. Point 5, hereditary structure. And these diseases is before eruption, and the second group has code K03, and this group, diseases of this group, appear after eruption, and this group is called other diseases of hard tissue of teeth. This group includes such diseases which we are going to study this semester, and they are excessive attrition of teeth. It's the same like pathological abrasion, and it has code K03.0, excessive attrition. K03.1, abrasion of teeth or wedge-shaped defect. Next, K03.2, erosion of teeth. K03.3, pathological resorption of teeth. K03.8, other diseases of heart tissue like sensitive dentin or irradiated enamel. Sensitive dentin, the same like hyperesthesia, and irradiated enamel, it's type of necrosis of heart tissue after irradiation, after the special factor. And K03.9, diseases of heart tissue of teeth unspecified, like acid necrosis. This disease, exactly, acid necrosis, corresponds to code to this group, which is has code K03.9. This is classification of disease international classification of diseases, characterized special codes. All of them start with K0 or K03, and we are going to study this semester only this group, exactly this group K03, which appear after eruption. Before eruption, it's up to children dentistry. And first disease is excessive attrition of teeth or increased tooth abrasion hard tissue of tooth, and it's code K03.0, excessive attrition. This is pathological process that results from tune function. There are three states of hard tooth tissue. First, absence of abrasion, next, physiological abrasion, and the third one, pathological abrasion. Sometimes people has physiological abrasion. It's not pathology like the first one, absence of abrasion. This is process that it expressed to various degrees in each person as a result of the physiological function of teeth chewing. It's normal physiological abrasion. But when a person has pathological abrasion, we have to do something, we have to treat it. And pathological abrasion or excessive attrition of teeth has special causes. For example, occlusional state like direct, oblique or mixed bite, partial unsubstituted adentia, occlusional disturbance, prosthetics, errors, professional features, concomitant diseases, bruxism, bad habits, some concomitant non-carious lesions. There are local causes of pathological erasures. Sometimes it may be acid food. Acid food contributes to abrasion, but bruxism, parafunctional, remains the main cause. Erosion of the enamel reveals a softer dentin, after which this process is much faster. Local erasure can be caused by bad habits, holding some things, tools, nail in mouth, biting the wire, the habit of gnawing seeds, and so on. As a result of repetition of movement between the front teeth, a characteristic notch forms. And excessive attrition, according to classification by Groshikov, has 3 clinical degrees. Degree number 1, first degree, slight erasure of only enamel of the tubercles and cutting edges of the crown of teeth. Degree number 2, enamel erosion of cusps, premolars, molars, and cutting edges of incisors with dentin exposure. First, dentin exposure, the second degree. And the third degree, erosion of enamel and significant part of dentin to the level of the crown of the tooth. And there are 3 clinical forms of increased tooth abrasion or excessive attrition: horizontal, vertical, and mixed. Horizontal form, erasing teeth on a horizontal plane with a decrease in their height as they erased. Vertical form, erasing of teeth on a vertical plane, mainly on the vestibular surface. And mixed form, equally vertical and horizontal, including sometimes from the oral surface. And it has excessive attrition, has clinical symptoms. Localized depressions of the enamel and dentin on one occlusal surfaces, sharp edges of teeth that injure the mucous membrane of the oral cavity. When dentin is exposed, it erased faster, leaving sharp edges of enamel. Also, hyperesthesia, exposure of the cavity tooth with the development of pulpitis and periodontitis. Change in the appearance of a person due to decrease in the lower part of the face. Decrease in the height of the bite and, as consequence, a pathology of the temporal mandibular joint. Deterioration of efficiency chewing food. Defect of enamel and dentin are clinically determined, which are localized on the cutting edge and chewing surface, which leads to decrease in the height of the lower part of the face and possible development of syndrome of Kosten syndrome, which includes 3 symptoms: burning or pain, hearing loss, and generalized abnormal tooth abrasion or excessive attrition. As for treatment plan, first we have to identify and eliminate adverse factors. Next, if it needs grinding sharp edges of teeth, elimination of hyperesthesia if it exists, if necessary, endodontic treatment, prosthetic with face restoration of teeth, dentition and normalization of the height of the bite. With a localized form of increased abrasion of individual teeth, it's possible to repair defect using glass ionomer, cements, or composites. Remineralization course and general treatment like medicine with calcium, fluoride, multivitamins with minerals, and in stressful situation, sedation. Next disease is called wedge-shaped defect, and according to classification, international classification of disease, it is called abrasion of teeth and has code K03.1. During this disease, there is V-shaped or wedge-shaped decrease in the hard tissue of the tooth localized on the vestibular surface in the area of the necks of teeth in the cervical part of teeth. Etiology. Abfraction occurs when the tooth is put under excessive pressure during chewing, occlusal pressure, and defect in the place near gum in the cervical part of the tooth. Causes and mechanism of formation wedge-shaped defect. There are two groups of factors, general and local. General factors. It may be thyroid dysfunction, diseases of the digestive system and nervous system. As for local, it's abrasion, action of external abrasive materials on the tooth with improper aggressive brushing of teeth, and abfraction, eccentric occlusal overload of teeth, violation of the bond between hydroapatite crystal, making the cervical region more susceptible to abrasion. And there are some provoking factors for wedge-shaped defect. It may be small vestibule of the oral cavity, anomalies of attachment of the frenulums and mucous cords, malocclusion with traumatic occlusion, combination of the deep bite and crowding of teeth, untenable prosthetic and orthodontics treatment, functional overload of teeth, bruxism due to systematic excessive pressure on the teeth. And according to curves, there are classification on phases. First phase. The exacerbation phase is caused by adverse changes in the background pathology. Tissue loss proceeds quickly. Hyperesthesia intensifies. And the second phase, which is stabilization phase of stabilization, is characterized by the slow development of wedge-shaped defect over the course of a number of years. Its increase is hardly noticeable. The sensitivity of the neck decreases and disappears. And another classification by stages. First stage, according to depth. First stage, initial manifestation without lesion visible to the eye, diminished tissue, identifying using magnifier, sensitivity to external stimuli is increased when staining with 5% tincture of iodine, a thin strip is detected. Only first stages, first initial lesions. Sometimes we can't see it. Second stage, superficial wedge-shaped defect in the form of slit-like enamel lesions. The depth is up to 0.2 millimeters. The length is about 3 and 3.5 millimeters near the enamel dentin border. moderate hyperstagia. It's well stained with iodine. Third stage, middle wedge-shaped defect formed by two planes located at an angle 40-45 degrees. The depth is about 0.2 or 0.3 millimeters and length about 3.5 till 4 millimeters. The yellowish color of smooth dentin is characteristic, stained with iodine. Hyperestasia may be absent. And the fourth stage, a deep wedge-shaped defect with a length of 5 and more millimeters, and it's accompanied by damage to the deep layer of dentin up to the cavity of the tooth. The bottom at walls are smooth, shiny, stained with iodine. Hyperestasia may be absent. Clinical manifestation of wedge-shaped defect. As for complaints, there are some options. Maybe no complaints, or maybe increased sensitivity when brushing teeth, for example, or maybe aesthetic defect. Anamnesis for a long time, maybe, or more often several years, if, for example, stable course. Objectively, on the vestibular surface in the neck of area, we can see defect within the enamel or enamel and dentin in the form of wedge with a smooth, dense surface. The color of the defects is either unchanged or pigmented. Probing and percussion are painless. Reaction to cold is painful and short-term and may be painless. Electrical excitability corresponds to the norm or it's slightly reduced. The number of teeth involved in the process may be various. More often, canines are affected, and also premolars. And it stained in active phase with iodine. And as for differential diagnosis, we have to differ this disease with some other diseases like erosion, hyperplasia with erosive form, fluorisis erosive form. These three diseases are non-carious and also with superficial and medium caries. And here you can see difference between these diseases. Difference in characteristics of defect, time of appearance, localization on the teeth, the number of teeth involved in the process, presence of hyperestasia, and coloring. According to these signs, we can differ exactly wedge-shaped defect from each of these diseases, from erosion, from hyperplasia, fluorisis, and caries. Treatment. Shallow defect in the first and second stages are not sealed. We use remineralizing therapy with calcium, with fluoride. In case of defect in the stage 3 and 4, after 3 months in the exacerbation phase or 1 month in the stabilization phase of complex remineralizing therapy, we have to fill such defects with composite or compomer or maybe glass ionomer cements. As for prevention of wedge shape defect, we have reject the abrasive toothpaste and horizontal movement in patient when brushing teeth. Soft toothbrush with rounded bristles, fluoride and calcium containing gel-based toothpaste and rinsing are recommended in such patient. Next disease in this group is erosion of teeth. Tooth erosion is a gradual loss of the normally hard surface of the tooth due to chemical non-bacterial process. Erosion in the eating away of surface. The word erosion comes from Latin erode, meaning to eat out. Erosion. Causes. There are some theory of appearance. First, mechanical theory. This is an excessive mechanical impact on the enamel, namely the use of hard toothbrushes, whitening toothpastes, and powder with high abrasiveness, abrasive toothpaste with especially whitening effects. Also, as for chemical theory, this is the effect on the enamel of aggressive chemical agents such as acid-containing products and some pickles, citrus fruit juice, carbonate drinks, etc. In the risk group for the development of tooth erosion are workers of harmful industries associated with the inhalation of acid fumes, metal particles, and mineral dust. The damaging effect on the tooth enamel has a number of medicines, for example, with a high content of ascorbic acid, vitamin C. Also, general reason: chronic gastroesophageal regurgitation, reflux, gastroesophageal regurgitation in gastroesophageal reflux disease can cause tooth erosion because it's due to acid which affect the tooth. Other reasons like endocrine system, endocrine theory. It's based on the relationship of tooth erosion with hyperthyroidism. It was found that in patients with thyrotoxicosis, tooth erosion occurs 2 times more often than in patients with normal function of this gland. Pathogenetic factors contributing to erosion. The first, diseases of the thyroid, parathyroid, sexual glands involved in calcium phosphorus metabolism. Next, increased salivation in hyperthyroidism. Saliva contains less mucin and minerals, therefore it forms an incomplete pellicle and has worse remineralizing properties. Number 3. Violation of the function of the central nervous system contributing to hypersalivation. And number 4. Features of the diet with a predominance of acid foods and drinks and reflux which deplete the buffer properties of the saliva, can destroy defective pellicle and cause surface demineralization of enamel. Thus, erosion can be seen as a result of alternating demineralization and abrasion. Classification of erosion. According to the depth of the lesion, there are 3 stages of erosion, 3 degrees. First, initial, the defect of the surface layer of enamel. Medium, defect, the entire thickness of the enamel to the enamel dentin connection. And the deep degree, defect enamel and surface layer of the dentin. During the process, there may be 2 clinical stages: active and stable. Active, rapidly progressing with severe hyperesthesia, and the stable, slow flow hyperesthesia is weak. As for symptoms, in the initial stage there is a loss of enamel gloss in the limited area of the vestibular surface of the tooth. At this stage, the signs of the beginning of erosive process can be noticed only after dyeing the tooth surface with air stream or applying with iodine tincture to the site of the lesion. In this case, a yellow-brown staining of the erosion site occurs. Initially, the erosive defect is a rounded or oval hard bowl shaped with a solid, smooth and shiny bottom. With the expansion and depending on of the hurt, there is a complete loss of enamel and exposure of dentin. At first and second degree of erosion of teeth, defect has a whitish color. At the third degree, there is a light yellow or brown pigmentation. In the active phase, with an aggressive and deep degree, hyperesthesia is noted when cleaning teeth, the action of chemical and thermal stimuli. The most frequently observed damage is symmetrical incisors, canines and premolars. Enamel erosion is often combined with pathological abrasion of hard tissue of teeth, and the course of tooth erosion is chronic, progressive, characterized by a gradual defect of a new teeth, tooth by tooth. We have to differ erosion teeth from wedge-shaped defect, tooth decay, caries of enamel and dentin, destructive form of hypoplasia, and erosive form of fluorosis. As for treatment of erosion, first, we have to identify and eliminate the cause, the reasons of erosion. Proper cleaning of teeth, the appointment of little abrasive toothpaste, treatment of background pathology, correction of diet, and especially the choice of drinks. As for general therapy is remineralizing medicine. and as well as local remineralizing therapy. Surgical treatment of defect, we have to prepare cavities and fill them with composite material or glass ionomer cements. And the last disease is called necrosis of dental hard tissue. It occurs as a result of negative endogenous factors or exogenous. As for endogenous, it may be dysfunction of endocrine glands, diseases of nervous system, chronic intoxication, toxic cause of pregnancy, etc. As for external or exogenous factors, it may be chemical factors, radiation, toxins, and so on. And mixing combined of external and internal factors, which lead to necrosis. Endogenous necrosis or cervical necrosis, extensive, rapidly progressive demineralization of tooth enamel without visible causes. It occurs in the pathology of protein and mineral metabolism associated with a violation of the activity of the endocrine glands, often against the background of hyperthyroidism, especially in combination with pregnancy. Clinical manifestation of the endogenous necrosis. First, changes in the optical properties of enamel of a large number of teeth, loss of gloss, extensive white margin spots, which are then pigmented. The difficulty and roughness of enamel when probing, loss of enamel due to peeling and erasability, pigmentation of exposed dentin and hyperestasia. Often necrosis begins with the vestibular surface of the incisors, canine and premolar teeth region. Then it spreads circularly throughout the neck of the tooth and capture other surface, forming extensive but surface located enamel defects. Treatment of endogenous necrosis. Detection and treatment of background pathology. For example, patient should be treated by endocrinologist. Courses of general remineralizing therapy for at least 3 or 4 months a year with control of calcium and phosphorus level in blood. Antioxidant preparation. Local treatment involved the removal of necrosis tissue followed by local remineralization. In the future, after 1 or 2 months, selective temporary filling of individual teeth with the use of therapeutic pads based on calcium hydroxide for 1 or 2 months is carried out. Only after that we have to fill the cavities with permanent fillings, permanent seals. And we use composites, compomers and glass ionomer cements. Acidic necrosis of dental hard tissue. This is also non-carious pathology characterized by the destruction of dental hard tissue under the influence of acids or acidic product. It may be professional harmful effects of acids. Frequent use of acid-containing foods, beverage, drugs, hydrochloric acid in disease of gastrointestinal tract, inhalation of toxic fumes for drug intoxication, commonly affected disappear in the regulation of these diseases, and teeth has sharp X. Clinical manifestation of acid necrosis. In the later stages of this disease, pain from temperature and chemical stimuli appear. The initial stages are the same like endogenous necrosis, and later stages characterized by pain. With the progression of necrosis, the enamel loses its luster, becomes dull and rough, and after complete loss of enamel, dentin pigmented and becomes dark. Complete dissolution and erasure of the tooth crown may be observed in advanced cases. Differential diagnosis of acid necrosis. We have to differ these diseases from superficial, middle, caries and also caries in the stage of stain. Enamel hyperplasia, erosive and destructive forms of fluorosis, hereditary lesions of teeth, and enamel erosion. As for treatment, it can be divided into general and local. General treatment: immediate cessation of maximum reduction of chemical agent. Reduce or ban itself. The intake of drugs containing calcium from 3 or 4 weeks till several months, with a break of 2 or 3 months, and multivitamins. And local treatment: the elimination of the hypersensitivity. For this purpose, application containing calcium and fluorine are used. Softening tissue are prepared and sealed cavity. It's best to use glass enamel cement for sealing. For preventing purpose, it's recommended to conduct a course of remineralizing therapy 2 or 3 times a year, as well as treatment of tooth surface with fluoride or local use. Prevention measures: elimination of aggressive factors provoking necrosis of dental tissue or limiting their impact. Correction of diet, reducing to a minimum the use of sour and sweet foods. Pay special attention to the quality of the oral hygiene and visit the dentist regularly. That's all. The lecture is over. Thanks for attention.
Make the ground shake.